As we continue this conversation on immunology, the next thing we're going to talk about is the type 3 hypersensitivity reactions, also known as immune complex hypersensitivity reactions. What you see in this situation is a combination of an antigen with a small immune complex may form, such as IgG, or they may begin to stack because the antigen has multiple sites. So as a consequence, you develop a very large immune complex because of these chaining effects of the IgGs. As a consequence, this develops debris in the vasculature, which then eventually begins to affect the kidney function and causes complement activation and neutrophil activation, which when this stuff is deposited in tissue can cause tissue damage that is unexpected. So you see these large complexes, they sort of float around and then they go to areas where there's no reason for them to be activated, but as these immune complexes sort of lay down and the actual neutrophils and cytotoxic T cells will come around and cause damage to the benign tissue. Example of this is things like amyloidosis, which is an accumulation of what's called insoluble fibrillar proteins called amyloid. Amyloid can actually be deposited in the heart, vasculature, smooth muscle, kidneys, adrenals, GI, nerves, and skin. Your clinical manifestations include for the airway macroglossia, which is enlargement of the tongue. In cardiovascular, you can get conduction disturbances, including right heart failure, and you can also develop pulmonary hypertension from the amyloidosis deposition, causing elevations in pulmonary artery pressures and right ventricular failure. The renal systems will, as amyloid begins to deposit, will develop what's called nephrotic syndrome. Nerves will develop autonomic neuropathy and nerve compression from scarification from the amyloid deposition. The next type of hypersensitivity reaction is a type 4. Type 4 hypersensitivity reactions are usually there's no antibody involved in this. Instead, it's usually the antigen exposure causes tissue and organs to be involved. The response time usually is not acute, but rather delayed, usually between 48 to 72 hours. Usually we'll see is erythema and induration in the areas where they've been exposed to this antigen. Several hours, several days, day or two later. You see histologically when you do biopsies of it, you get monocytes and lymphocytes, and the actual delayed type memory is caused by T cell activation. Examples of this would be a delayed time reaction, would be like a tuberculin test. Patients have been exposed to poison ivy, things like that. Let's talk about a different subject matter, which is drug allergies. Drug allergies can be potentially lethal to individuals. These allergies can be antigen to antibody specific. This is a typical example. That is heparin-induced thrombocytopenias. From prior exposure to heparin, the patient then forms antibodies to heparin, and upon re-exposure to it, then the patient will have destruction of the platelets, and we'll also get a stacking of red blood cells, which should eventually develop what's called white clot syndrome. It can cause significant problems in these kind of individuals for those kind of problems. In addition to that, you can get symptoms very much similar to anaphylaxis, including hypotension, bronchospasm, urticaria. The antigen-antibody response is usually from a prior exposure, and it's usually rapid onset. As for drug toxicity, this is usually manifested depending on the drug and the concentration. This is fairly predictable, and we know when to stay away from certain drugs levels to keep the toxicity away. And it's not really an allergy, so it's something completely different. About 60% of the perioperative drug-induced allergies are due to muscle relaxants, which is a high incidence of cross-sensitivity. The quaternary ammonium compounds, so the non-depolarizers, have the most allergy specific. The benzoyl isoquinolones are also responsible for a certain degree of not so much allergy, but release of histamine in the cells. As for your induction agents, barbiturates have less incidence, but if you do get prior exposure to barbiturates and do have an allergy to them, it can be rather severe. Propofol, because of the carrier, we have people that have egg allergies, especially the egg lecithin emulsion. It can cause bronchospasm in some individuals that have this allergy. As for local anesthetics, this is thankfully rare. It accounts for about 1% of adverse reactions. The ester-based locals have a paraminobenturic acid, which is used as a preservative, very similar to methylparaben and propylparaben. This is the one that usually accounts for most of the reactions that you see. We do know there's no proven cross-reactivity between esters and amides, and most of the time the actual dentists using are amide local anesthetics. So if the person says they're allergic to it, if it's not really an epinephrine reaction but a true allergy, you can still use an ester in them, and then they actually will do just fine. Opiates are rare. One of the things that you can do is if you give high enough doses of morphine, you can get a very similar reaction to allergies, but it's not really a true allergy. It just causes histamine release, and as a consequence, it looks like more like an anaphylactic reaction. Volatile anesthetics, you can get allergies, especially halothane hepatitis. This is from the formation of trifluoroacetyl halide metabolites and the activation of hepatic microsomal proteins, which develops a neoantigen, which upon re-exposure to halothane, that person develops severe inflammatory reaction inside the liver, causing halothane hepatitis. Sevoflurane, on the other hand, does not produce oxidative halide metabolites. It's considered safe and it's not considered allergenic. Protamine is another drug that we use very commonly post bypass to reverse the effects of heparin. Protamine is made from actual salmon sperm. As a consequence, it's a fish product, and people that have fish allergies should not really receive these products as they can form very severe anaphylactic-like reactions. The other things that you'll see is that patients that are allergic to, that have prior exposure to diabetics may also have protamine allergy. The reason for diabetics to develop a protamine allergy is because protamine is a stabilizing agent in insulin. So if you look at the insulin very carefully, you'll see that it says insulin and it includes protamine in it. So the other thing that we'll also notice is that men who have had vasectomies and their own sperm causes an antibody activation can also cross-react with protamine injections. And what you see with protamine is it induces a complement activation cascade in releasing thromboxane into the pulmonary circulation, which causes acute pulmonary hypertension. That's usually how you pick it up, and profound hypotension peripherally. So what you see in these kind of situations, despite a drop in blood pressure, you see an elevation in PA pressures, which is consistent with acute pulmonary hypertension. Antibiotic-wise, vancomycin is one of those very dangerous drugs that we have to give in the operating room. Should be giving it over an hour. Please don't give it any faster than that. If a person is given inadvertently vancomycin too rapidly, the patient can develop what's called red man syndrome, which is a life-threatening, almost anaphylactic and anaphylactoid-like reaction. The other thing that vancomycin is a cardiac depressant, so it's a really double whammy effect. So it vasodilates you, plus it then also causes cardiac depression. As for the penicillins, which are very commonly administered to patients, there's about a 5% crossover rate with the cephalosporins, so you have to be very careful administering these medications. Penicillins are theoretically high risk for allergies if the person has a prior penicillin anaphylactic reaction with cephalosporins, so just be aware. As for blood products, when you give it to people, there's a 3% incidence of allergic reactions, even with properly cross-matched blood. You don't see this very often most of the time because the blood banks have really taken more of an active role in trying to diagnose any kind of issues that people would have with cross-reactivity. The other thing that can happen is if patients are given sugars that they make prior exposure, such as dextran or hydroxyethyl starch, the dextran allergy reacts with antibodies to viral or bacterial polysaccharides. And as for the anaphylactoid reaction, dextran can actually activate complement and induces a renal failure in some people. Latex is becoming an increasing instance in medical personnel. And around 15% of anesthesiologists at this point in their careers now are developing some form of allergic reaction to latex. Usually this occurs from long-standing exposure. Partly this is a problem since the HIV epidemic era, where gloves were used extensively, and unfortunately the manufacturers had basically been rushed to increase the production of these latex gloves, which left a lot of impurities in them than they prior to that time they'd had. As a consequence, people have become very sensitized to latex, and anything that has any kind of white milky substance, when you remove it from its outer shell, like a banana or mango, these people have a much higher tendency to have a cross reaction to those kind of fruits and vegetables. The other thing that you'll see is patients have been prior exposed to latex catheters, including Foley catheters, such as patients that are usually with spina bifida. These people have a very high incidence of severe forms of latex allergies. And when they're telling you that they're really latex allergic, I mean, it's full-blown anaphylactic reaction that can be life-threatening. And a lot of people don't take it seriously enough until we see it happen. You need to basically move towards, in the last few years, to a latex-free environment. If you do have a patient with history of latex allergies, you need to consider getting them H1 and H2 blockers, and also considering high-dose corticosteroids prior to them receiving surgery and exposure to these latex particles. If you look at, there's different forms of latex sensitivity, of course, and we look at it from basically three aspects. The reaction could be as irritant dermatitis, or a type 4 delayed hypersensitivity, or a type 1 immediate hypersensitivity. Let's go to the immediate hypersensitivity first. This can be cause life-threatening it's life-threatening anaphylactic reaction in these individuals. This is an IgE-mediated reaction. These people will get immediate hypotension, bronchospasm, and exposure to contact of latex. So you have to really pretty much follow the anaphylaxis protocol, including giving them epinephrine. And some of these people need immediate intubation when they go into the full anaphylactic shock. And unfortunately, these might be some of your healthcare personnel. So really avoiding latex in these individuals is really critical. A lot of times what you end up seeing is that these people have to stop staying in the medical field because the latex is, at least was very prevalent in the past. If you see a person with a type 4 delayed hypersensitivity, they get itching and blistering that can occur 6 to 72 hours later. This is usually found as chemical additives that are used in the manufacturing process known as accelerants. Basically, you are trying to identify the offending chemicals and try to avoid them as much as possible. As for the irritant dermatitis, it can cause significant scaling and drying or cracking the skin. And again, the best thing to do is to avoid it, latex at all times. You have contact dermatitis. Could be caused by many different things in the environment. It could be from skin proteins or molecules that are more complex, and these things will then cause activation and rashes in individuals. As for anesthesia-wise and the immune function, resistance to infection is something that's of course critically important. And some of the anesthetic agents that we deliver do suppress the immune system, but they tend to be reversible and transient, and they tend to be minor immunosuppressions, including nitrous oxide. And local anesthetics actually inhibit polymorphonucleosides entrance into the wound, which is also a detrimental thing, as it may actually increase the proliferation of bacteria in that situation. Stress response to surgical trauma is actually much more important as immunocompetence, as you can also become immunocompromised from surgical stress. There's also disorders of different kinds that can cause problems for individuals. The first one we're going to talk about is the disorders of antibody production. There's people with X-linked agammaglobulinemia, which is inability to form any class of antibiotics. These people have recurrent bacterial infections. You have also acquired hypoimmunoglobulinemia, or or selective immunoglobulin A deficiency, which can cause a lot of sinus tract infections and pulmonary infections, because IgA is really used by the pulmonary and sinuses mucosa to prevent infection. There's also people, of course, with lymphocyte deficits that can be seen from either other forms of cancers or just lack of it due to radiation or some kind of exposure to some kind of chemical which suppresses the system. This causes a person to become significantly immunocompromised over time. As for the disorders of immunoglobulins, you have things called cold autoimmune diseases where abnormal proteins agglutinate in response to cold. You get to what's called cryoglobulinemia, which is cold agglutins activate complement and platelets, so you get hyperviscosity, and the patient eventually develops renal failure. Anesthesia-wise, the importance is that you need to keep these people warm at all times, and you can't allow them to get cold. And you really can't give them any kind of cold blood as well, because you can get yourself into trouble pretty quick. There's also this thing called cold hemagglutinin disease, where IgM binds to erythrocytes when cold. This causes hemolysis, complement activation, and purpura, gangrene, and nephritis. The last one that we'll talk about is B-cell maturation in myeloma. Multiple myeloma is a B-cell cancer. It's a proliferation of a single clone of B lymphocytes. What you see in this picture is basically the actual B lymphocytes being hyperproliferative. They produce high levels of immunoglobulin, which eventually destroys the kidney. And the other thing it also does, unfortunately, is it begins to invade into the surrounding bone marrow and causing destruction and compression fractures throughout this individual, and their bones become extremely brittle. The last disease of immunoglobulin disease is what's called Waldenstrom macroglobulinemia. It's a neoplastic proliferation of IgM secreting plasma cells, which leads to hyperviscosity, infiltration of the liver, spleen, lungs, and bone marrow as well.